Good morning, everybody. I'm sorry I can't be with you in person today. I was appointed Medical Director of the NHS at the end of 2007, just as the stroke strategy was launched by Roger Boyle and the Stroke Association. And a lot of progress has been made since then, but I'm still left with a persistent feeling that there is considerable unfinished business. I think the evidence that we still need to focus on stroke is as strong as it was then. It remains the fourth commonest cause of death in this country, the commonest cause of adult disability. It costs the NHS just over £3 billion a year. It costs social services over £5 billion a year. And the hidden costs of treating stroke, when you take carers and the costs of the economy and other factors into consideration, are really quite considerable. And it seems to me that we're doing a lot of pieces of work that simply need to be joined up, and that being able to develop a coherent plan is not that far away. Firstly, we need to do work on prevention. There's quite a lot of work already going on around the reduction of cardiovascular disease risk factors, and that needs to be coupled with a focus on the identification and treatment of people with atrial fibrillation. Secondly, we need to continuously improve the quality of care that we offer people who have been unfortunate enough to have a stroke. The SNAP audit has been absolutely fantastic in helping us to understand how we can improve. In addition, we know that when the HAZU model is implemented properly, we can get some very significant gains in terms of mortality, reduced length of stay, greater return to independent living, and savings that can be made for the NHS that can be reinvested in services. More recently, attention has started to focus on the opportunities that thrombectomy may offer, and NHS England has committed £80 million over the next 5 years to see how we can provide a decent thrombectomy service across the country. Now, I don't think that's going to be easy for 1 minute. It's going to require careful consideration about how those services are located, what kind of workforce is required, and what it means in terms of reorganizing existing services. But the best people to engage in that conversation are the sorts of people who are sitting in the room today. The next area that I think we need to focus on is rehabilitation and the support for people who have had strokes. I think at the moment rehabilitation is the Cinderella specialty in many areas of endeavour in the NHS. I think stroke could start to lead the way in demonstrating just how important it is in terms of giving people a decent quality of life. As a cardiac surgeon, I've been very clear in my own mind about how important rehabilitation is in helping somebody to get over a major intervention. But stroke is so much worse and requires so much more support. And finally, an area that needs considerable focus, I think, is workforce. And given the shortage of workforce almost across the board that we have in the NHS at the moment, we're going to need to think really radically, particularly if we want to bring new, exciting treatments like thrombectomy to patients. That's going to mean that we will have to tackle some professional vested interests. We're going to have to explore role substitutions, and we're going to have to explore who may be able to do procedures who previously haven't been able to do procedures. And then finally, we need to explore the relationships between people who have similar types of skills related in particular to over-the-wire technologies, because I'm sure there will be an economy of scale between, for example, cardiologists, neuroradiologists, and other interventional radiologists that may help us get to a solution to the workforce problem much quicker than if we try and just seek out increased numbers of existing specialty practitioners. So it seems to me that we have the opportunity and basis for a plan. NHS England is working very closely with the Stroke Association, and it's my anticipation that my successor, Steve Powis, will continue this work with the Stroke Association so that we can develop something that is not a vague document, but actually outlines a very clear plan for improving stroke services across the country. But I also need to be clear that that needs to involve all of you. This must not be a top-down endeavour. We in NHS England must be responding to what you think needs to be done for our patients. May I just add that I think it's vitally important that the Stroke Association play a very leading role in the development of this plan. I don't say that gratuitously. I say it as someone that has worked very closely over decades with the British Heart Foundation. And one of the things I've learned working with major charities is that they are trusted by the people that they seek to serve. They have a deep knowledge of the topic, and they generate good research. And a combination of those things puts them in a very commanding position to understand the totality of the issues that need to be tackled. And furthermore, they bring a level of independence from some of the institutions of the NHS. It's inevitable that developing a plan won't be easy. It will be difficult, and it'll be difficult because lots of people will have lots of really good ideas. It will be difficult because some of those ideas will clash with vested interests, and it will be difficult because getting any plan through the financial and other bureaucracies of the NHS can be tricky. But nevertheless, I have great confidence that the evidence on which we base this plan that demonstrates the need will win the day.
Given the ongoing workforce recruitment and retention issues within the health and care system, which are likely to be exacerbated by Brexit, we'd welcome your comments on how NHS England, in association with Health Education England and others, will address these issues across all healthcare professions in stroke to ensure delivery of the new national plan for stroke, which you mentioned.
That's quite a complex question. When I look at issues that the NHS has had to address over the last decade or so, there was a period where we had to focus on waiting lists for diagnosis and treatment. There was a period where we've had to focus very, very hard on the amount of money in the face of austerity, and now we are entering into a complex period where we're going to have to address some very, very difficult workforce problems, not least of all that we don't have enough workforce to deal with all the issues we've got to deal with. Brexit compounds that in the sense that we know that about 10% of our doctors come from the European Union. We know that many of them are not feeling welcome, and I would like to be absolutely clear to anybody in the audience who comes from the European Union, you are highly valued, and that we are very grateful for the contribution that you're making, and I would invite you to stay, irrespective of some of the public discourse about Brexit. But I think there are also some complex issues which people in the audience need to help NHS England and Health Education England think on. You know, when you don't have enough people, you have to think about different ways of delivering things. And I've already alluded to the fact that there will be vested interests, that people who want to hang on to the sorts of procedures that they do don't want to share them. People who have similar skills that cross over, that may be of value. We need to explore that. I gave thrombectomy as an example. So I'd invite those in the audience to work with the Stroke Association and in turn with NHS England to help us overcome some of these problems. Just waiting for more workforce is no solution, because that's not going to happen anytime soon. So we need to be imaginative in the way we approach this. We are working with Health Education England to see what to look at the whole pathway of stroke and to see where the gaps are in workforce, but that needs to include different ways of doing things.
Stroke research, compared to other important disease areas, remains relatively underfunded. Therefore, we'd welcome your comments really for how this will be addressed in the future with respect to research across all parts of the stroke pathway, both in hospital and in community settings.
I think there are certain aspects of stroke research which are underfunded, but if you look at the totality of research which contributes to the benefit of stroke patients, there's probably more funding than immediately meets the eye. So when you look at the amount of research that's funded by the British Heart Foundation, some of it in conjunction with the Stroke Association, by the Medical Research Council, by the Wellcome Foundation, on things such as cardiovascular risk factors or on heart rhythms, in particular atrial fibrillation, you'll start to realize that there's quite a lot of research that is funded under a different label to stroke. Having said that, there are some very specific areas where I think we need to do more research, and that's particularly at the tail end, if you like, of the stroke pathway. So, for example, around the sorts of support that people need. And we're just in the process of discussing at the NHS England board how we can develop a much closer working relationship between NHS England and the NIHR, with a view to them helping us fill in some of the gaps in pathways that we consider to be important priorities for the National Health Service. And I think you'll see that, that discussion mature towards the end of this year.
Finally, Sir Bruce, thanks very much for being part of the opening plenary session today. Is there anything else you'd like to add before we finish?
Yes, there is actually. You know, one of the great privileges of the job that I've done over the last decade is the ability to work with so many talented and really dedicated individuals who simply want to make our NHS a better place for our patients. And today I'd like to pay particular tribute to Tony Rudd, who's put in long hours and many miles over many years to keep the focus on stroke. And I think without his contribution, along with his work with the Stroke Association, we wouldn't be here talking about the next plan for stroke for the NHS. So thank you very much, Tony. And more recently, may I just say thank you to Matt Kearney, the National Clinical Director for Cardiovascular Prevention, who's done so much work on focusing attention on the reduction of cardiovascular risk factors and the identification and treatment of atrial fibrillation.